Wild Health is about optimizing you. We use genomics, blood work, biometrics, microbiome assessment, many other tests, and a conversation with you to come up with a full health optimization plan. What's the perfect diet, exercise, and supplement plan for you and only you? The Wild Health podcast is about optimizing all of us. Here we cover the cutting-edge science that gives you the base to be able to apply the personalized plan we give you as a patient. To sign up as a patient, go to wildhealth.com. Or if you're a physician or health coach and you want to learn how to do this for your patients, we're happy to help as well. Wildhealth.com for all the information on becoming a patient or working with us.
Hey, everybody, and welcome back to the Wild Health Podcast. I'm Mike Stone, and I am thrilled today to have Dr. Doug Lucas with us. So, Doug, we were chatting a little bit beforehand. Your bio is so exhaustive that I think we'd have to dedicate a podcast to explaining your background and your accomplishments. And I say that partially to rib you a little bit as we jump on, but really so impressive what you've done right now, working on optimal human health. But why don't we start off a little bit with your background, how you came to be doing the work that you're doing now, and then I can pick your brain with a million questions that I have for you. So thanks for spending time with us.
Yeah, thanks. I'm glad you hit the record button because I think we could have just kept going there for a long time. So thanks for having me. Happy to be here. Love this podcast. Love the topic. I think you guys do such a great job. So really happy to share what I've been doing with you. My background started in orthopedics. So I'm an orthopedic surgeon by training, still a board certified orthopedic surgeon, but I haven't practiced in that space since about 2020. I was one of many docs, I think, who got into the field of medicine in their chosen career and then felt a little bit dissatisfied with what they were finding. Not that surgery wasn't fun. I loved operating. I loved being in the operating room, and I think we did incredible work. But what I found, and I know you found this too, is that I was really just cleaning up metabolic disease. I was chasing the tail end of poor health and bad either decision-making or following bad leadership from someone. And they ended up in my office and needed a surgery. I was really interested in getting away from that and getting into more of the preventive space. And honestly, the pandemic allowed me the opportunity to make that leap with a whole bunch of other things into optimal human health. So now run a telehealth business. We are focused almost exclusively on bone health at this point and provide a platform and a membership that allows people to come in, improve bone health. We're reversing osteoporosis on a regular basis, and I'm happy to say that boldly and proudly. We're doing it without drugs for the vast majority of people, and it is a really, really fun space to be in because there's so many, let's call it controversial areas that we can talk about.
Yeah. So exciting and such a, we chatted a little bit about this before we hit record and I usually leave things said up front, out of the picture, but I think this one is worth repeating. Bone health is done, and talk about bold claims. I'm ready to go there. Bone health is done so poorly in the Western world that shining a light on how to do it more effectively. I'm not saying your job's easy, but man, you're starting from such a great place because the bar is set so low that if we're able to, and I'd love to hear your thoughts on why is that an issue that bone health is sort of an afterthought in Western allopathic medicine, even osteopathic medicine, right? This is just a thing that's like, by the way, like when you're 60, go get a DEXA and see what your bone health looks like. Oops, you have osteopenia, osteoporosis.
Right. Yeah, if you're lucky, that's the path, right? Most people, we see people in their 70s that come in with their first scan because they had a fracture. You're right. Our system, the traditional medical system, is really good at some things, and I never disparage doctors. And honestly, I don't really disparage the system because it does some amazing things. However, it is terrible at preventing some of the chronic diseases that you and I talk about most often. Osteoporosis is definitely one of those. There was a study I looked at recently that looked at the likelihood of a diagnosis of osteoporosis and treatment of osteoporosis after even a clear and obvious fragility fracture, which is a fracture from frail bone by definition. And it was somewhere around 20%, meaning that 80% of people that had obviously had the disease were never referred for treatment, were never put on any kind of treatment protocol, and were never even receiving a diagnosis. It just goes completely missed in urgent cares, in emergency rooms, even in inpatient admissions. And I, as an orthopedic surgeon, am also guilty of this in the past, where someone had a fragility fracture and we didn't go down the pathway of saying we have to diagnose this correctly as a pathologic fracture. This is a fragility fracture. This person needs specific follow-up care. We ended up creating that pathway, but it did not exist in the practice that I was at, nor has it existed in really the 3 practices that I've been at in my career. So it is just a sorely missed topic that once it is addressed, the solutions in the traditional medical system are also pretty miserable. The system is designed to be done as effectively and efficiently as possible, and it a lot of times focuses on the efficient, not the effective. And so most doctors who are treating osteoporosis do so with the intent of preventing fractures. I do too. We just use different tools. In the traditional system, you've got 5 minutes to see your patient. The only thing you can do is prescribe a drug. So again, I don't disparage doctors for using drugs. They're trying to prevent fracture. Totally get that. But osteoporosis isn't a drug deficiency problem. It's not a calcium deficiency problem. It is really a sign of overall metabolic dysfunction that can come from so many different things that we should get into. But really, it is the end result of a lot of things happening that result in poor bone metabolism. And once you find that out, figuring out what the solution is the way to resolve it naturally. But that takes a little bit of education and sometimes a lot of work.
And I'm just going to paraphrase what I'm hearing from you, which is, wait, there's a functional medicine approach to osteoporosis. It's not a one-size-fits-all disease process. Amazing. Right. So I got to share one thing with you before we dive in, which is I went to medical school, in the dark ages, and planned to become an orthopedic surgeon when I went to medical school. And I ended up through, the grace of the universe being paired up for my intern summer between first and second year of medical school with a spine surgeon as an orthopedic interest, and it died on the vine right there. Because for anybody listening who doesn't know, spine surgeries are, somewhere between 12 and 18 hours, and they're really, really brutal. And I was like, this is not what I thought orthopedics was going to be like. So had I been paired with a foot and ankle or a shoulder surgeon or a hand surgeon, things might have been very different for me professionally. But the thing that always appealed to me about orthopedics was, I think it's like emergency medicine. I think it's a beacon for what Western allopathic medicine does well, right? You break a bone, to be able to fix something and put it back in place and come up with a functional, outcome where people are able to perform at the level where they were before the injury. That sort of acute trauma care, I think, is really, I talk about the system being broken, and I'd say it the same way. The system's broken for preventative care and for helping people lead joyful, purposeful, healthy, vibrant lives. It's not broken for, I got hit by a bus and I need to be in a trauma center. It's outstanding for that. So, I think we probably shared some common interests back in the med school days, and then I got steered away with spine surgery. Okay. So why don't we start from the start, and, what is, briefly, because we could go all day just on this, what is osteopenia and osteoporosis? How common is it? Who does it affect? And what do we think the main drivers of osteoporosis are?
Yeah, boy, I could talk about that for a long time. So let me just talk about the definition, because this is a really confusing topic where when people think now in modern culture of the last 15 years, people think osteoporosis, they think T-score, they think DEXA generally. And everybody's heard about DEXA, which is the traditional screening modality for osteoporosis. But if you break that down, DEXA is really just a type of an X-ray. It's measuring bone density or mineralization exclusively. It says nothing about bone quality, which is a problem, and I'll get into. The definition of osteoporosis is based off of that imaging study because the medical system needed some way to objectify fracture risk, and that was the best thing that they had at the time. It's not a particularly good test. It is neither precise nor accurate. But we really have nothing else to compare it to except for some new technology, which I'd love to talk about. But the definition is based off of the number of standard deviations. We get into statistics here, but the number of standard deviations below the mean bone mineral density for your matched race and gender. And so you see a T-score, say, of negative 2.6. That's 2.5, actually it's 2.6 standard deviations below the mean of someone with peak bone mineral density of your gender and race. And so there's a lot of confusion around that because my 60-year-old patients are like, why are you comparing me to my 22-year-old self? But we do that because we know what the starting point was, and then we can identify the trajectory from there. So osteoporosis is just that specific statistical measurement over negative 2.5, so negative 2.5 and below, technically. Osteopenia is negative 1 to negative 2.5, so 1 to 2.5 standard deviations below. Osteopenia is technically not even a diagnosis. There's no ICD code for osteopenia. It is just the trajectory from hopefully where you were, which was hopefully normal bone, into osteoporosis. Osteopenia is also not necessarily an issue depending on the trajectory. If your bone is stable and you're osteopenic, like mine is, I'm not particularly worried about my fracture risk. But if it's continuously getting worse, that's a problem. So the biggest thing I wanted to get out of talking about the diagnosis with you is recognizing when we should be diagnosed and when we should be screening. Because what I just said is an important point that gets missed a lot, which is that hopefully you started with good bone density, but we almost never know. Never do I have somebody come in with osteoporosis that had a DEXA done 40 years ago or even 20 years ago when they were 40 years old. We really need to know early because we see it in a young population very frequently in our practice. So I'd love to get that across. The second part of your question got into sort of the risk factors, but I'm going to pause there and see if you have any questions on that.
Yeah, I mean, I think that no questions on DEXA and T-scores. I do, I mean, osteopenia, I don't think it's a perfect analogy, kind of like the pre-diabetes to osteoporosis, except, if it's, I think the difference there is you could have some osteopenia that's super stable and never really causes you any issues. And I do think that insulin resistance, even in the early stages, has probably got some downstream metabolic effects you want to avoid. Yeah. So, but I think if you off the shelf, if you're new to this, you just want to think of osteopenia as sort of the precursor to osteoporosis or a risk factor for osteoporosis. I think that's holdable as a concept. So yeah, let's talk. Well, first of all, I think I know where you're going with this, but I don't like surprises. So better test than DEXA for bone health.
So let's get into that. So I mentioned that DEXA only looks at bone density. If you think about bone strength, it's really a combination of density and quality. We see people with very low T-scores, meaning like -3, -4, -5, that have pretty good bone architecture and they don't fracture. I mean, not that they never fracture, but they're not as likely to fracture. But it's really hard to measure bone quality. And there's a couple of tools out there that try to do this. But the least invasive or non-invasive way to do it is with ultrasound. So an ultrasound machine from a company called Echolight, they have a device called REMS, and a REMS is an ultrasound that is designed specifically to look at bone, and it can do the same thing looking at your lumbar spine, looking at your hips. It'll give you a T-score just like a DEXA, but then it also has enough data to tell you about the architecture of the bone, because ultrasound can look through the bone and get a sense of what that architecture looks like, both bony and the collagen part, right? So it can give you a sense of quality. And then you compare the quality score with your T-score, and it really helps us to get a sense of what we should be doing for this patient. Unfortunately, the way that this evolved is that DEXA was deemed the gold standard for bone health testing. And so now anything else that comes up has to be essentially tested against DEXA. So that has been done. It is relatively consistent, but not perfectly. And there are some extreme variations where I have a patient that had a -5 T-score on DEXA and a -1.5 T-score on REMS. And then you're kind of left scratching your head like, well, I don't know which one to believe. My bias is I think the REMS is probably more accurate for a number of reasons. But when something is the gold standard, you can never prove that something else is better unless there's a third test to compare it to. We don't have that for bone. So we are kind of stuck now with one test that's covered by insurance that everybody's going to have, and another test that's not quite as globally available that people are getting, and they don't really know what to do with the two things. So that's the other test that we use, and whenever possible, we use both.
Got you. And REMS, just for anybody interested, is radio frequency echographic multispectrometry, which is, like many things in medicine, why we abbreviate it, because nobody wants to have to say that. My past life, I was not just an emergency physician, but really specialized in the use of point of care ultrasound. And I just love seeing how these assumptions around medicine change over time. We were told that ultrasound couldn't be used to look at the lungs because it doesn't penetrate air. And now lung ultrasound is one of the frontline diagnostic tools for pneumonia, collapsed lungs, pneumothoraces, fluid in the chest cavity, et cetera. And then same thing for bone, right? Can't use it for bone. And it turns out it may be better than DEXA. Right. But yeah, definitely. How do you tell if it's better if you're comparing it against the thing that is thought to be the source of truth? Right. So I'm not surprised that you're using both. Do you, is this something that, like, how easy is it for someone to, you're a telemedicine practice, right? People aren't coming in and getting their REM studies done in your office. 50 states, easy enough to find? Is it challenging to find a place to get REMS?
So right now, I would say this is a rapidly expanding market. So there's a lot of people in the bone health space, people who have franchise branches that specialize in bone health, et cetera. They're realizing, hey, if I have one of these $50,000 ultrasounds, I can provide this service for patients and probably make my money back, maybe. But it is becoming more and more common. They're popping up all over the place. So we have we put it out on our channels occasionally, but we have an up-to-date list. Whenever we learn of a new one, we put it on there. And there are actually a number of mobile services now that are going around to different kind of bone health centers around the country. So you have to look a little bit. If you happen to be close to one, it's great, but most people are not.
And then are you interpreting these results? Should they come to you with a T-score the same way that, you're interpreting the T-score, obviously, but do they come to you read and sort of with results? Is there a radiologist read on these? How do these get processed?
Yeah, there's no radiology read. The report's pretty good, honestly, by itself, but people always have that follow-up question of, well, what do I do? A lot of the centers that offer these will offer to read it for someone, but they're not going to provide clinical advice. So they're still left with that same question. So we do get a lot of questions about that on our YouTube channel and in our different various platforms. Interpreting it can be challenging, but it's an easier interpretation than it is from a DEXA. DEXA can be very challenging to interpret. Gotcha.
Okay. So when should somebody be looking at getting a DEXA or a REMS?
Yeah. So if I had my way, I would have everybody at probably 25 years old do a REMS, which is totally unrealistic and is never going to happen. But if you break down maybe at-risk populations, this is a totally reasonable thing. And the reason why you want to know in your mid-20s is that's really when most of us reach peak bone density. So you can imagine then how important adolescence is and what you're eating and what activities you have. But let's just assume that, whatever happened. And in our mid-20s, we get a REMS, preferably because there's no radiation and it's maybe more accurate. Then we at least have a starting point to know how aggressive we should be or what kind of activities we should do or potentially not do as we age. And it's weird to think about that. It's hard to think about longevity in your 20s, but honestly, that's really when we need to start. If not then I think that all women, as they start to go through kind of the perimenopause transition into menopause, somewhere around there, you have to know. Because as a woman loses estrogen and progesterone and potentially testosterone, they go through menopause, it falls off a cliff, they're going to lose bone. It is absolutely predictable in the next 5 to 10 years, you're going to lose a fair amount of bone. If you don't know what your starting point is, you are really flying blind. So definitely know before you go through that change. And then you're also going to be able to use those tools to say, hey, what is my risk-benefit conversation around hormone replacement therapy? Because that's a really powerful tool. And without that information, you really can't make a decision around that with your provider.
I think there's something that just got dropped in there that I know you're going to expand on, but it's a critical point, and I think it's one that's often overlooked, is the role of hormone replacement therapy for women in the menopausal phase, perimenopausal, postmenopausal phase in prevention of the progression of bone loss and osteoporosis. I think most of us think in, Western, just sort of civilian society about hormone replacement for cardiovascular purposes. Maybe people have concerns about risk factors around heart disease or stroke or even Alzheimer's disease or cancer risk. And these are the kind of the concepts that float around hormone replacement therapy. And I think very few people take into account that osteoporosis prevention is a tremendous benefit from hormone replacement therapy for women in menopause, perimenopause. So can you expand a little bit on that? I know that, you started off without medications for the management of osteoporosis. And I'd be curious if hormone replacement fits in that category of medications for you, or if you're thinking more along the lines of things like alendronate and like classic prescription medications for osteoporosis.
Yeah, thank you for letting me clarify that. So when I talk about reversing osteoporosis without drugs, I'm referring to bone health drugs. So the bisphosphonates, the Prolia, the Evenity, and even the anabolics. Although if I were to choose one, anabolics are the one that I would choose in certain circumstances. When I think about hormone replacement therapy, this is an area where when I was going through training and I got introduced to orthopedics, I never, ever thought that I would be running a practice that specialized in hormone replacement therapy. I literally just started a new business and finished writing a book on hormone replacement therapy. Because what I learned when I started getting into the bone health space is that, we have to offer this. It is such a powerful tool. And then when I started going down the research rabbit holes, I have this other fellowship, this board certification. We talk all about hormones, but until you start dissecting the literature yourself, you really can't get a sense of how crazy the hormone space is for women and men too, to some extent, but really for women. And what's happened over the last 25 years is so confusing for consumers and for doctors, honestly. And so it's such a challenging space. But what I love about being in bone health, again, it is sort of at the center of all of these really controversial and critical topics. The thing that's so cool about bone health is that bones leave biomarkers. So we can watch what happens even in short-term studies with bone health as we either, add, subtract progesterone, estradiol, testosterone, DHEA. Bones leave biomarkers, whereas heart and brain health, so much harder to study. So in the new, in the menopause space where there's a lot of really great thought leaders and people that are putting out great information, and typically I hear, because it's just in my feed, but I hear people say hormones for bone, heart, and brain. And I think that's great, except the data for heart and brain is nowhere near as clear as it is for bone. It is so obvious. And I just went down this rabbit hole for the book, and I ended up writing probably about twice as long of a book as I intended to, because the studies on the bone health side make the hormone picture so much more clear. When it comes to the risk benefit around estradiol in particular, we're talking about estrogen risk. There's so much conversation around cancer, so much conversation around what about the increased risk of heart attack, of blood clot, of all these other things. But the truth is, when you dig into the literature, you find that estradiol is really not the culpable partner there, that really it is the confusion of all the synthetic drugs, the way that the studies were done, the additional, call them risk factors that are in there. When you start to pull out the different areas, you realize that estradiol itself has a pretty clean track record. It's just really confused. But when you look at the studies on bone health, you can see just how powerful it is. And I was just looking at this meta-analysis that broke down all these different estradiol studies, and you see improvements of up to 10% in 12 months of BMD with estradiol alone or in conjunction with progesterone. But that's an amazing improvement. I mean, that's unheard of. And yet this is something that could be done and continue to do, unlike the bone health drugs where you have a very limited time frame. So it's a massive tool.
Okay, so clearly in menopausal women, you're pushing hard on hormone replacement therapy or medical hormone therapy, depending on whose nomenclature you like to use these days, and obviously, for folks who don't have contraindications where it's appropriate, et cetera, like you're doctoring, I get it. What are 2 or 3 or 5 other things that you think are non-negotiable tactics for women to or men to either reverse. It's bold. I love that you're saying reverse, or even just prevent the progression of osteopenia, osteoporosis.
Yeah, well, let me just comment on that. The first part of that, which is, yeah, we're doctoring with hormones, and not everybody is a candidate. So I don't want people to think that there's no risk to estradiol and that everybody's a candidate. That's not true. But the challenge around that conversation that I see is that most doctors don't have a good understanding of the potential benefit. And all of us as doctors, we're trying to stratify risk. We're making a risk-benefit equation in our head for every patient with a million risk factors. So it's a really challenging thing to do. But most doctors are not thinking of what is the potential benefit for your bones or potentially your heart or brain, but it's so clear for your bones. Then compared to these risk factors. So I hear all the time, a woman, let's say, she has one immediate family member with a history of breast cancer who developed breast cancer at 85. She's 60 and she was told she can't go on estrogen as a result of that. That is nonsense. Her risk is the absolute same or near the same as a woman without that other risk factor in there. And so again, like if she has osteoporosis, even if she had 3 family members, it would actually still make sense for me. And I'm in a unique situation where I'm dealing with people that are at risk of fracture. They're more likely to have a fracture and die from the complications of that fracture than they are of developing breast cancer. And so it's just a different conversation. And so we push, I don't want to say we push heavy, but we're definitely willing to have that conversation with the women that are outside of the quote unquote magic 10-year window, women that have a stronger family history of estrogen receptor sensitive cancers. We just kind of go down all of these potential risk factors and say, well, what's more likely to be an issue? And we can't be right. We can't always know what the future holds, but at least we can have the conversation so they feel heard and they feel educated about their decision. So just wanted to put that out there. So if I were to say, what are the top 3, 5, or 10 things? I was actually just listing this out this morning. So let me see if I can remember what I said. I think number 1 is going to be nutrition. Hands down, nutrition is the biggest player here, more so than estrogen, which I was just touting. But the reason why is because we see just globally in our patient population that has osteoporosis, they are undernourished, under protein fed, and have been that way for decades, if not their entire life. And I think this is a result of a lot of things. Women have in the age group of 45 to 65, they've been trying to be really thin. That was the look that a lot of women in this group are going for, and a lot of them have successfully been really thin. But as a result, they've been undernourished, underfed, chronically dieting, and they're just malnourished. So nutrition number 1, everybody comes in, we have them track their food in Chronometer, and we dissect that, and we make recommendations based off of that. And there's some pretty consistent findings. The biggest one of them is protein. Most of them are under eating protein. So then we have to work on that. Then I'll stop there. The second one is going to be gut health, because that's the next step. So a lot of times you tell, a woman, let's call her, as she's 115 pounds, 5'2" with osteoporosis, and she's eating 30 to 40 grams of protein a day. If you tell her to eat 120 grams of protein a day, it's not going to go well. So her gut's not ready to do that. And there could be a lot of reasons for that. So we used to make this optional, and now we just do it for everybody, which is to do a stool study, look at the microbiome, look at the gut function. We have to get the gut tuned up in order for them to be able to digest the building blocks that they need to actually build bone and muscle. So that's number 1 and number 2. Number 3, I would probably slide hormone replacement therapy in there because it is such a powerful tool. And it's not just estradiol. Progesterone plays a role. Testosterone can play a role, although not all women need testosterone, but all 3 of those primary sex hormones will play a role in there. Let's see here. Number 4, I would start getting into the physical side. So another massive commonality in this population is having never done resistance training, having never been exposed to that type of activity, and really being afraid of it at this point, for sure, because now they have osteoporosis, they're told not to lift anything. Resistance training is so important. Resistance training is key to building muscle. Now, to be fair, it's actually not going to build bone, but we have to build muscle in order to build bone. To build bone, you need to add impact to training. And I'm not telling anybody listening to this podcast that has osteoporosis to go jump off of stuff. That's a bad idea. But you can start small, doing simple things like heel drops, which may even not be appropriate for everybody, but simple things like a heel drop actually can generate enough multiples of body weight to stimulate bone Pair that with the right nutrition, the gun work, the hormones. That's gut work, not gun work. The gut work, the hormones, and the amount of protein, and you can start building bone almost for everybody. So I would say probably that was, what did I just do, 4 or 5? That was 5.
Yeah, 4, somewhere in there. Yep, fantastic. So let me ask you a couple of questions that I get all the time, and I have my own stock answers or thoughtful answers depending on how common the question is. But what about yoga? Is yoga enough to count as resistance training?
No. So there actually is one study. If you go to PubMed and you type in yoga osteoporosis reversal, you'll find a study by a guy who's a huge yoga advocate, you can imagine. But when you break down the study, the design was terrible. And so it just sort of like cherry picked data and found that there was an improvement in this subset of the population. But when you look at what yoga is, it is fantastic. And I'm not going to say that yoga is not good for you. But if your goal is to build muscle and bone, it's not the answer. I love for patients to add yoga in, but it has to be on top of the resistance training and the impact. For me, it's probably like 4th or 5th or 6th important down the line. I almost don't really even look at it as exercise. It's really more of a meditative state. It's more of a, for me, the way I do it, more of a meditative state. It's more a mindfulness practice than it is an exercise, if that makes sense.
Yeah, it does. I mean, I think from a flexibility standpoint, obviously lots, and a balance standpoint, those are other, key levers that are important as we age. And I think there's, I definitely will not incur the wrath of the yoga fanatics and yoga fans. I know many of them. I like to do yoga myself, but I think it's not a substitute for actual resistance training with regards to bone development. And then, are you seeing a lot of what? Well, let me not like assume the answer. How have semaglutide, tirzepatide, the GLP-1s played a role, if at all, in the spectrum of bone health that you've been seeing over the last 2-3 years?
Yeah, I don't think we're seeing it yet, but I think it's coming. And my concern with the GLP-1s and GIPs, I think they're interesting drugs. Little background here. My wife runs a weight loss company, and she uses behavior and nutrition as the primary tools. And she's so just emotionally against GLPs. And I get that. The challenge that I see is that for patients who are on GLPs who aren't supported appropriately, they tend to lose muscle mass in a disproportionate way. We know that muscle mass loss, or sarcopenia, the medical term, is strongly associated with osteoporosis. I don't know which one's the chicken and which one's the egg, but if anybody's losing muscle mass more than they need to, I'm concerned. I see people who are going on these drugs having a successful weight loss journey, and they're realizing, man, I got to stay on this thing forever. The side effects of the drugs, because of the way that they make you feel when you eat satiating foods, particularly high protein, high dietary fat foods, you don't feel good. So I was on Ozempic or semaglutide just actually to see what it felt like, because I was considering prescribing it, and I do have a few patients on it. And I remember the first time I ate a steak on a GLP-1, I couldn't eat for 36 hours. So that really concerns me for my bone health population. So I do not recommend these drugs unless they're going to microdose it and track protein and make that the first thing you eat. I don't care if you go on a carnivore diet, but you have to make that the first thing you eat, because you're not going to be able to eat all of your nutrients.
Love that. And I mean, just not to digress into GLPs and GIPs and, the upcoming 5th generation glucagon inhibitors. I think that's the key differentiator across the board is dose and support. And if you're getting it from your esthetician at a, maximum dose for maximum weight loss effect, you need to be really, really, really careful about what you're doing. Okay. This is worth diving into for a second. So when we talk about DEXA, when we're thinking about bone mineral density, we're talking about a traditional DEXA scan typically has, images of the lumbar spine, both of the hips, looking at generated T-scores, letting you know how dense your bone is. And then a lot of folks in the wellness, fitness, nutrition, optimization space use DEXA interchangeably to describe the sort of body composition DEXA, where you're looking at appendicular lean mass index, so skeletal muscle mass. You're looking at visceral adipose tissue. You're looking at body fat percentage, subcutaneous body fat or total body fat.
Yeah.
And often in those, you'll get a global or even broken down by part of the body, like skull, ribs, arms, legs, DEXA scan, or not DEXA scan, excuse me. You'll get a global bone mineral density.
Right.
Complete garbage from a osteoporosis standpoint, useful. I'm going to assume not a substitute for a comprehensive bone mineral DEXA. But what do you do with that information when somebody comes to you and says, I got my body composition DEXA and my T-score was 1.2?
Yeah. So I think it's going to depend on the DEXA. And unfortunately, it's kind of hard to know because you don't know, like, what's the machine, what's the history. In general, we're looking at the lumbar spine, L1 through L4. We're looking at the hip specifically. I look at the femoral neck because I'm worried about that thing breaking. Some people use the total hip or, whatever, a couple of different measures there. DEXA can be really confusing in reports because you're right. It can break down every single, body part. It just depends on how it's programmed. Or it'll give you a whole body bone mineral density. There is some research on whole body bone mineral density, but in general, in the osteoporosis space, we're worried about the spine and the hip because those are the areas that we see fracture. It's not nonsense though. And I've had plenty of people come in, especially in like YouTube comments, they're like, I had a body comp DEXA and my bone mineral density was low. What do I do? My answer is, well, before you do anything, go get a specific DEXA for that thing because we want to know, like, how far off is that? Because it's probably not that accurate. So if it's low, absolutely. And if you've had a body comp DEXA, it's probably listed on there somewhere, and your provider, whoever was reviewing it with you, if you had somebody, probably didn't talk about it because I don't really know what to say about it. I've had one young patient, she was 46 at the time, who had a body comp DEXA, and she sent me the results, and I was like, hey, because she wasn't there for osteoporosis. So it was like, hey, did you know you have osteoporosis? She's like, what do you mean? Totally had no idea. So it is on there and it's a good way to screen, but I wouldn't rely on that as a diagnostic tool.
Okay. And then give me your 2 cents. And well, it's not just your 2 cents, like you're freaking board certified orthopedic surgeon who specializes in bone health. So give me your 20 cents on, the pharmacologic agents for osteoporosis. So, I'll share a personal story. She doesn't listen to the podcast and she wouldn't mind anyway, but my mother has osteoporosis, extraordinarily resistant to the idea of resistance training, which I've been pushing incessantly on her for the last 25 years. Definitely, protein deficient, all of the things that, I know what I'm doing here. I can't make people do what I want them to do, especially if I'm related to them. It seems like it's, if anything, less effective than if they were a stranger, but has gone down the route of some of the pharmacologic interventions for osteoporosis. And just curious, sort of, do you see any role for these? And what, pros and cons, risks and benefits to some of the more commonly prescribed osteoporosis medications. Because if you just go see your regular doctor, odds are, and you have osteopenia, osteoporosis, odds are they're going to do some calcium supplementation, think about putting you on alendronate, and that's going to be the recommendation. So I think listeners probably need to know kind of, well, what else is there? And I think we covered kind of more of the lifestyle and, nutrition, training, it's gut health, et cetera. But what makes you pull back from those medications as a first line intervention? Yeah,
when you spend time with groups of people with osteoporosis, you find a very strong resistance to the drugs. And if you look statistically, it's around an 80% quote unquote failure rate. And it's not a failure rate of the drugs necessarily, it's that people just don't want to take them. And the reason why, there's just a lot of fear. There's certain drugs in the market that just drive a lot of fear, like statins drive a lot of fear. These bone health drugs are no exception. I look at the drugs as an option under certain circumstances, all of them potentially. But the circumstances have to be very clear and the timeline has to be very clear. So I look at them as kind of two different groups. There's the anti-resorptive drug. So that would be like alendronate or Fosamax you mentioned. There's a lot of bisphosphonate drugs like that. Prolia is a very common one these days, every 6-month injection that works similarly, but different mechanism. All of those drugs work to slow down bone metabolism and slow down bone loss. they are literally poisoning the cells that break down bone, the osteoclasts, or blocking how they function, one of the two. And when you do that, you cannot break down bone. So as a result of not being able to break down bone, the cells that build bone, the osteoblasts, can't do their job either. Imagine trying to like remodel a highway, like you're doing road construction without taking down the old road. You can't build a new road without removing the old road, or like a new building without taking out the old building. You have to break down to build up. So when you poison one side of the equation, the other side goes away too. So we see patients come in on these drugs and their bone turnover markers are all depressed. CTX, P1, and P are the two that we use most commonly, and they're basically flatlined. They just have no bone metabolism. So then the side effects we worry about with those drugs are the two that most people talk about would be what's called an atypical femur fracture, which is a fracture in an odd place in the femur that results from a brittle but usually dense bone. Somebody that's been on a bisphosphonate for a long time, or Prolia for a long time. And then osteonecrosis of the jaw, or ONJ. And that one is gnarly if you have
terrible
bone loss in your jaw that can result in fracture, chronic infections, teeth falling out. It is absolutely debilitating, and don't Google it. It's terrible to look at. Those things are possible because when you stop the metabolism of bone, they can't do what they're supposed to do. So all of these drugs have a timeline that people are recommended to be on them, and it's not as long as you might think. 3 years to 5 years, I think maybe 7 years, depending on the study and recommendation. But if you're 50 years old, that ain't going to do it. You need another option. So a lot of times you'll see people go on these drugs, and their doctor will at some point say, hey, you should go on a quote unquote drug holiday. And they'll either put them on another drug in the meantime, or they'll just take them off drugs and then sort of cross their fingers and tell them to, take more calcium, which isn't going to help. And then they'll put them back on the drug. We don't have any data on like the sort of leapfrog approach to osteoporosis care like that. And from my perspective, if you're squashing bone metabolism, it's going to continue to be a problem, and it's just going to get worse over time. So I always say there's a time and a place. So what would that time look like for anti-resorptives? I think for women that are being treated for some kind of estrogen receptor positive cancer, if they're on a drug that is withdrawing estrogen from their body for a particular period of time, these drugs can help to limit the side effects of those drugs, and you come out on the other side of that treatment successfully with more bone. That's actually a pretty good use of pharmacological therapy. Are there potential risks? Of course, but you're being treated for breast cancer, so there's risks to all of that. So that's a good example of a situation where that makes sense. Same thing could be said for men with androgen deprivation therapy, et cetera. And then there's the other class of drugs. So there's the building up drugs. So this would be like your Forteo, your Temlos. These drugs don't squash bone metabolism. They amplify bone metabolism. So actually, when somebody comes in on these drugs and they're like, hey, can I stop my drugs? I'm like, no, don't you dare. This is going to amplify everything that we do. As long as you're tolerating it, you're not having bad side effects. Let's stay on it, because you're going to build a ton of bone while we're doing this. And if I could just sprinkle it in everybody's supplements, I would totally consider doing that, because it just amplifies it. Now, they're not without risk, but you can't take them for very long, 1 to 2 years max. So again, not a solution for the long term, but it is an option in the short term to get somebody out of a really deep, dark starting point, multiple fractures, really low T-score, bad bone quality, et cetera. Let's give them the boost that they need to get them out of that.
And what's the limitation? Like what's the concern for being on for more than a year or two? Is it just that we don't have data on it? Is there a malignant risk? Is there a fracture risk? Like it's a malignant risk? Yeah. So
the studies that were done to get this to the human trials were done in rats that had a propensity for cancer. I don't know why they chose that model. But when you do a rat study on a rat that has the propensity to develop cancer, and you give them a drug that develops bone at really high rates, it's no surprise that they develop bone cancers. The most common bone cancer they developed was osteosarcoma, which is a nasty cancer. And so there was this fear that if you gave this to humans for too long, they would develop osteosarcoma. So the human trials, I think they only went out a year. It's been a while since I looked at it. And then FDA initially approved them for up to 2 years of use because of the concern for osteosarcoma. There was even a black box warning on the drug, may cause osteosarcoma. The thing is, in humans, osteosarcoma is not typically a cancer of elderly individuals. It is a cancer of young individuals. So I don't think there has ever been a single reported case of osteosarcoma in a human who was taking these drugs. So could they be used long-term? I don't know. But I don't know any doctors that's going to prescribe them long-term either.
Got you. Well,
Slim.
This is, just like our conversation before we hit record, we could go for another like 2 or 3 hours here, but for the sake of listener attention spans, I think we'll land the plane on episode 1 with Dr. Doug. And I can't thank you enough. This has been, really exciting and interesting for me to hear more about your perspective and take on this. If people want more Dr. Doug in their lives, which I'm sure they will, best place to find you outside of your website, which we can link to in the show notes. Where else can people go? I know you've got a book. I know you've got an active Insta feed. Where would you direct people?
Yeah. So if you're interested in bone health topics, our YouTube channel called The Dr. Doug Show is just, I spend probably about half of my professional time researching and creating content for The Dr. Doug Show. It's all about bones and hormones. So that's a really good place to go on YouTube, and then Instagram at Dr._Doug Lucas, Instagram, Facebook. We feed a lot of that same material to those feeds. So those would be great places.
Amazing. Doug, thanks so much for coming on with us. It's good to see you again. And we'll look forward to maybe a follow-up episode sometime in the near future.
Yeah. Thanks, Mike. Yeah, I'd love it. This is, like I said, topics that I could talk about for days.
Amazing. All right. Well, thanks again. I appreciate you, buddy.
Thanks.
Thanks so much for listening to the Wild Health Podcast. If you want more daily health education, be sure to follow us on Instagram, which is filled with health optimization how-tos, grocery shopping lists, guided breathwork posts, myth debunking, and so much more. You can find us at Wild Health MD on Instagram.